Please, I
Sorry,
cannot hear Dr. Isa. Okay.
my slide is not moving. I don't know.
You can stop sharing and share again if it
Yes.
happens like that.
Okay.
Please, sorry, while waiting for Dr. Isa to start
Okay.
sharing,
So
please
he's
note
back.
that
Okay.
attendance has been launched on the poll. Please kindly fill in the attendance. Thank you.
Okay. So this is going to be the outline of my of the discussion. Introduction, acute complications, sickle cell crisis, types of sickle cell crisis, predisposing factors, sickle cell crisis management. We'll look at the painful or vaso-occlusive crisis, sequestration crisis, and aplastic crisis. Sickle cell disease is the most common inherited genetic disorder. It results from the inheritance of two abnormal genes controlling the formation of the beta chain of hemoglobin, one of which must be the hemoglobin S gene. The hemoglobin S gene is due to a single base change, adenine replaced by thymine in the gene coding for the amino acid in the sixth position of the beta globin chain. This, of course, leads to an amino acid change from glutamic acid to valine. And these are the various variants of sickle cell disease, depending on the change on the amino acid that is replacing the glutamic acid at that position 6. For hemoglobin SS is valine, and then hemoglobin S, C, SD, various other amino acids are replacing glutamic acid. The clinical manifestations arise from the tendency of the defective hemoglobin to polymerize and deform red cells into the characteristic sickle cell. The life of a sickle cell disease patient is characterized by periods of wellness that is known as steady states, which are punctuated by crisis states. Also acute, known as acute complications, which may lead to chronic complications, especially if not well managed. The overall goal of management of sickle cell disease is to improve the quality of life and life expectancy of the affected individuals. The specific objectives of management are: 1, to maintain a steady state of health, prevent and reduce the number of crises and complications, treat crises and complications promptly and effectively, and to promote a healthy lifestyle and positive self-image. So these are examples of acute complications. The first group is what is known as the sickle cell crisis. There are 3 of them: painful or vaso-occlusive crisis, also known as bone pain crisis, because it occurs mostly in the bones. Then we have the sequestration crisis and aplastic crisis. Previously, there was also the hemolytic crisis, but it's no longer considered as a unique entity because the sickle cell disease itself is a hemolytic state. There is actually an ongoing hemolysis that is occurring. That is why most of them walk about with jaundice, and that is what actually causes the anemia, depending on the individual. Some is moderate, some is even borderline of severe anemia as their steady state. Some of them go about with a PCV of or hemoglobin of 7 gram per deciliter, or PCV of 18, 19. That is their steady state, and it's because of the ongoing hemolysis. So it's not really considered as a crisis on its own, even though for some, once in a while, they may have an hyperhemolytic state, but that on its own is not enough to consider it as an entity again. Then some of the acute complications are priapism, acute chest syndrome, stroke, that is acute cerebral syndrome. There is also acute, they can also present as acute abdomen, and so on and so forth. So, but in this lecture, we'll just handle the sickle cell crisis, which are more common, and which are the most common presentations in our clinics that we see. So sickle cell crisis, the definition is it is a worsening of the symptoms and signs over a short period of time, usually associated with pain and or shortage of blood. Steady state is the interval between crisis when the individual is in relative good health. Comprehensive management of patient in crisis involves treatment of acute clinical problems during the episode and identifying and eliminating possible predisposing factors or triggers, arrangement to ensure continued care of the patient in steady or post-crisis state. So what are the predisposing factors for sickle cell crisis? This include exposure to cold or drenching by rain, physical exertion, dehydration, injury, including surgical injuries, psychological stress, idiosyncratic, which is peculiar to the individual, idiopathic factors that are unidentified, infections or infestations, and some drugs too can precipitate crisis. Initial evaluation of sickle cell disease patient in crisis include history, pain, self-assessment of pain, and prior treatment before presentation. This is very important. We need to listen to the patient and accept his own personal assessment of the pain. We should not classify the pain for him, because it is said that he who feels it knows it all. The person whose the shoes pinches knows where it pinches him most. So pain assessment, we should heavily rely on the patient's self-assessment. If the patient says that the pain is severe, we should take it as severe. If he says that the pain is mild or moderate, that is what we should go with in terms of planning for the treatment or instituting the treatment that can help him take away the pain. Drug allergies, we should ask the patient about drug allergies so that we'll avoid those drugs that will worsen his condition or complicate his crisis. History of increasing jaundice and passage of Coca-Cola colored urine. We should also ask about such history. And for babies, we should also ask the mother about whether there is fever, history of fever.
Can we still hear him?
No, ma'am. No, ma'am.
Okay, let's just be patient. I think it's temporary network issue.
In his hands and foot swellings. Then assessment of vital signs. As we're talking about physical examination, we should carry out a brief physical examination, measure the blood pressure, heart rate, respiratory rate, oxygen saturation, and temperature. Assessment of areas of bone tenderness, and so on. So for the abdominal examination and all the necessary examinations that we need to do depending on the presentation. Initial treatment of patient in sickle cell crisis include pain relief if it is a painful crisis, optimal hydration, identification and treatment of infectious and or other comorbid conditions, blood transfusion if necessary or where necessary, and we should also address specific clinical problems or those the triggering factors. Is there any triggering factor? We should identify it and remove it or treat it. Initial investigations that influence immediate management of sickle cell include full blood count, reticulocyte count, blood film examination, especially for malaria parasites, plasma bilirubin level, total and conjugated, serum urea, electrolytes, and creatinine, infection screening, blood, urine, stool cultures as necessary, and abdominal pelvic ultrasound as necessary, chest x-ray, pulse oximetry, transcranial Doppler ultrasonography, computerized axial tomography, magnetic resonance imaging. So we are going to take the entities, vaso-occlusive crisis. So this is characterized, this is the most common or frequent type of sickle cell disease, and it is due to obstruction of blood vessels, which leads to ischemia, infarction, and pain. And the main feature is sudden onset pain of varying severity, usually involving the bones. Sometimes it is associated with swelling and tenderness, like in children, in infants who will also present with with hands and foot swelling, known as dactylitis. There may be no history of predisposing factor. Management includes the outline of the management. We briefly evaluate patient within 5 minutes. We've mentioned those things that we need to do, and then administer analgesics and allow an appropriate interval for pain to subside before full assessment. It is very important that we don't waste so much time assessing and evaluating the patient while he's in pain. We should first of all relieve the pain within 5 minutes, make sure that the patient is calm, pain is taken care of, and the patient can then be able to even respond to our assessment or evaluation. Then ensure adequate hydration. For children, use 100 to 120 ml per kg per day. For adults, it's 1.5 ml per meter square per day, or on the average about 3 liters per day. 5% dextrose in water or dextrose saline is preferred. Hypertonic fluid such as 10% dextrose should be avoided. So this the table is a guide to the pain management. For mild pain, in adults, we can use dihydrocodeine 30 milligram 4 hourly plus paracetamol 1 gram 4 hourly. Immediate for those who are opiate tolerant, immediate release oral formulation of stronger opiates, e.g. morphine, can be used 4 hourly. And for children, paracetamol 2 milligram per kg 4 to 6 hourly, with or without ibuprofen 10 milligram per kg 8 hourly, or dihydrocodeine 1 milligram 8 hourly. For moderate to severe pain, in adults, we use diamorphine 2.5 to 5 milligram subcut 4 hourly, or morphine 5 to 10 milligram start, or pentazocine 15 milligram 8 hourly. We can also combine it with injection diclofenac 75 milligram 1 to 2 hourly after opiates. There is alternately or injection tramadol 100 milligram 1 to 2 hours after non-steroidal anti-inflammatory drug. For patients who are opiate tolerant, who are more resistant, we use to these opiates. We can use injection of opiates, diamorphine 10 to 20 milligrams subcut 2 to 4 hourly, and injection of opiates, e.g., or injection of opiates, e.g. pentazocine 30 to 60 milligrams 8 hourly. And for children, these are the dosages that we can use, the various dosages. And then we also need to give maintenance doses, slow release morphine 1 milligram per kg, rounded up to 5 milligram 12 hourly, with oral morphine 0.3 milligram per kg 3 hourly as necessary, or pentazocine at appropriate doses. And this can be given alternately with the diclofenac 1 milligram per kg after the opiates. Monitoring of the pain. Assess the pain relief every 15 to 30 minutes. Give antiemetics if indicated. And these are some of the antiemetics that can be given, because some of those opiates drug, they have nausea and vomiting as their side effects. Some patients, when they are given morphine or tramadol, they have nausea and vomiting. So we may need to give these patients antiemetics. Monitor pain, sedation, vital signs, respiratory rates, oxygen saturation every 30 minutes until pain is controlled and patient is stable. Then every 2 hours. If respiratory rate is less than 10 cycles per minute, omit the next dose of opiates and give naloxone 10 microgram per kg IV, followed by 100 microgram per kg. Discharge patient when pain is improving or control with reduced dose of oral analgesics. Arrange for home or outpatient follow-up appointment as applicable. Then there are instances where we may have to also give blood transfusion in vaso-occlusive crisis. And the indications are when the hemoglobin is less than 6 grams per deciliter or greater than 2 grams per deciliter below steady state value, or there are acute features of severe anemia. There is a cardiac compensation. Type and amount of blood. Red cell concentrates should be used. Raised to steady state level for adults. Give 10 mils per kg for children, and sedimented cells for adults raised to steady state level and give 15 mils per kg for children. Whole blood to raise to steady state level for children, give 20 mils per kg. So the recommended blood type is red cell concentrate or sedimented cells. But if it is not available, we use whole blood. And when we are using whole blood, we should also use diuretics like Lexis, pre and post transfusion to reduce circulatory overload. Treatment of infection. If the patient has features of infection such as fever, send relevant samples for microbiology and start broad spectrum antibiotics. Give malarias in malaria endemic zones. Sequestration crisis. This is pulling of a large proportion of blood in the spleen or liver. It usually occurs in children less than 6 years and in some hemoglobin SC or hemoglobin S beta thalassemia adults. It rarely occurs in hemoglobin SS adults. It is a major cause of death in children with sickle cell disease below 2 years. Sequestration crisis is characterized by marked pallor, precipitous fall in hemoglobin level, sudden progressive enlargement of the spleen leading to increase in abdominal gap, hypovolemic shock due to reduced circulating volume, and reticulocytosis and or nucleated red cells in the blood film. Treatment of sequestration crisis include rapid transfusion of whole blood or red cell concentrate, 10 mils per kg for red cell concentrate or 15 mils per kg for whole blood. Then exchange blood transfusion may also be done, but there should be caution here. The transfusion should be in aliquots. It should be gradual, not the full volume at the time, because when the patient is recovering and the blood is being released back to from the spleen or the liver where it is sequestrated, when it is being released, patient may suffer from circulatory overload. So blood transfusion is needed, but it should be done cautiously. Prevention of sequestration crisis involve teaching the parents or school teachers and caregivers how to palpate for enlarged spleen or liver, helps in early detection and reduces the mortality rate. Elective splenectomy after 2 episodes of sequestration crisis occurring less than 6 months apart is also one of the modalities of treatment. And the last crisis, aplastic crisis, this is an acute form of acquired red cell aplasia caused by DNA virus, parvovirus B19. Parvovirus B19 replicates inside immature red blood cells in the bone marrow, resulting in severe anemia. So the immature red cells where erythropoiesis is happening in the bone marrow, it infests those normoblasts and destroy them right in the bone marrow before they are even matured and released into the circulation. So that is what parvovirus B19 does. Features of aplastic crisis include weakness, uneasy fatigability, headache, fever, facial erythema, low hemoglobin, or gradual fall in hemoglobin. If you notice, for aplastic crisis, the fall in hemoglobin is gradual, over some days, whereas in sequestration crisis is sudden, is precipitous. In sequestration crisis, that is the difference. Then for aplastic crisis, there's reticulocytopenia, while in sequestration crisis, there's reticulocytosis. There is another difference. Then leukocyte and platelet count may be reduced, and serum IgM antibody to parvovirus B19 virus in blood will be positive. Treatment of aplastic crisis include these measures: isolate patient, especially from expectant mothers, to reduce the risk of fetal infection, transfuse blood with a target to achieve the patient's steady state hemoglobin level. Intravenous immunoglobulin should be given to immune deficient patients. Prophylaxis, that is prevention, vaccination of non-immune individuals who have sickle cell disease or other chronic hemolytic anemias. So the main reference for this lecture is SPARCO Standard of Care Recommendations for Tertiary Healthcare Facilities. Thank you for listening. So I think I will quickly go to the next
Yes.
lecture. Okay. Is my slide visible?
Yes.
Okay.
Management of chronic complications of sickle cell disease.
Okay, thank you. So last week during the lecture, we mentioned the various complications of sickle cell disease. And this slide is a recap of those complications. As we mentioned, that sickle cell disease is multisystemic disorder. It affects all systems and organs. And some of these chronic complications include avascular necrosis or osteonecrosis, cardiac complications, chronic hypersplenism, chronic pain, endocrine complications, impaired glucose tolerance, and parathyroid dysfunction. That is still under the endocrine complications. And then we have gastrointestinal complications, such as chronic sickle hepatopathy, viral hepatitis. Then we also have iron overload, especially coming from chronic blood transfusion, chronic and multiple blood transfusions. We have chronic leg ulcers, nocturnal enuresis, ophthalmologic complications, psychological complications, pulmonary hypertension, which is under cardiac complication, renal complications, seizures under neurological complications, and then we have stuttering or recurring priapism. And we should remember that management of chronic complication in particular is multidisciplinary. We should not forget that, because no one can do it all. If we are practicing in a tertiary hospital, we should always consult our other professional colleagues as necessary, to consult them or to send the patient to them. And if we are practicing in a secondary hospital or primary healthcare center, we should identify. That is one of the aims of this lecture, for us to be able to know this complication, identify them as early as possible, and refer the ones we can treat and handle, we handle. If the patient needs to be stabilized, we stabilize him before we quickly refer, because some of the complications, especially the acute ones, they are time-bound. It's very important to intervene as early as possible. So, and for the chronic complications, we need the other specialists. No one can do it all, as I mentioned earlier. So evaluation for avascular necrosis, evaluation include X-ray of the joint and if possible to obtain MRI early in the course. Management include counseling the patient to minimize movement and bearing heavy weight on affected joint. Administer analgesics, non-steroidal anti-inflammatory agents, plus or minus opiates if necessary, and then refer for orthopedic assessment, treatment, and for surgical management. So the orthopedic surgeons, they need to come in as early as possible. Give disease-modifying therapy, such as hydroxyurea, to prevent progression or involvement of other joints. Then for chronic leg ulcers, assess the wound and document the size, appearance, status of the surrounding skin, presence of tenderness, edema, and femoral lymph nodes enlargement. Do a full blood count and blood culture and sensitivity if associated with cellulitis or abscess formation, or if there's a discharge, there's the wound is, or the ulcer is discharging, and if there's also associated fever and bone tenderness. Do imaging studies, e.g. X-rays, such as X-rays, MRI, to exclude osteomyelitis, and take biopsy for histopathology when malignancy is suspected. Apply graduated compression bandages to reduce lymphedema. Elevate feet when sitting to improve blood circulation to the ulcer. The patient should learn to elevate his feet when he's sitting down, or even when he's lying down on the bed. He should put a pillow under his feet to improve drainage and blood circulation. Apply wet to dry dressings twice a day, and consult the surgical team for surgical debridement and skin grafting when indicated. So here, the plastic surgeons are also important. We need to consult them or refer the patient to them for if the patient needs surgical intervention and debridement. Give zinc supplementation, and a new agent, voxylator, is also being investigated for use for patients with chronic leg ulcers. If there is associated pain, treat the pain with adequate and appropriate analgesia. Usually the pain is neuropathic in nature and is treated with amitriptyline. Consult vascular surgeons if features of arterial insufficiency are present. Consider regular blood transfusion until the wound heals if the above measures fail. And consider discontinuation of hydroxyurea in patients with non-healing or slow-healing ulcer. explain to the patient that the ulcer may take a long time to heal. So this is very important because the leg ulcers can be very stubborn in healing, because it is multifactorial. So depending on the factors that are precipitating the leg ulcers, until those factors are able to be identified and taken care of, it can be very, very frustrating, and patients should be counseled, and enough explanation should be given to him, and his cooperation should also be sought. Patient need to cooperate and to be patient, while this management is going on. Cardiac complications. Assess all patients for cardiac symptoms, dizziness, chest pain, ankle swelling. Perform cardiac examination that includes assessment for signs of right heart strain at each annual review. Patients with cardiorespiratory symptoms and signs should be evaluated with electrocardiography and echocardiography. Echocardiography should be repeated annually in patients with previously elevated trioscopic regurgitant velocity who have not had right heart catheterization. Refer patients to a pulmonary hypertension specialist for consideration of right heart catheterization if the trioscopic regurgitant velocity is greater than 290 centimeters per second, or is between 250 and 290 centimeters per second. Do complete blood count, reticulocyte count, and peripheral blood film. Monitor spleen. Talking about chronic hypersplenism, which is one of the chronic complications of sickle cell disease. The assessment includes complete blood count, reticulocyte count, and peripheral blood film. Monitor spleen size and document at every clinic visit. Exclude and treat other causes of cytopenias. Do splenectomy if hypersplenism is associated with failure to thrive or chronic pain, and when hemoglobin and platelets are persistently less than 5 grams and less than 50 times 10 raised to power 9 per liter, respectively. Give penicillin for a minimum of 3 years post-splenectomy. So hypersplenism is different from splenomegaly. Hypersplenism is a situation in which the spleen, the function of the spleen is exaggerated. The spleen, we know, is like it's a reticuloendothelial organ. It can be involved as in hemopoiesis, extramedullary hemopoiesis, and on the other hand, we know it is like a filtering organ. So and that this function can be exaggerated, and then it is also like a storage organs, a pool for platelets, red cells, and even the white blood cells. So when this function is exaggerated, patient can present with cytopenias. We know that up to 90% of platelets can be pooled in the spleen at a point in time, and even the sequestration crisis is like part of the exaggerated storage system of function of the spleen. So that is hypersplenism. And one of the ways to know that it is hypersplenism is when you do your reticulocyte count and the reticulocyte count is normal or even increase. We know that it is hypersplenism that is causing the cytopenias. So we need to monitor the spleen and document it in every clinic and exclude and treat other causes of cytopenias. And one of the modality is to do a splenectomy if the hypersplenism is associated with marked cytopenias. Another chronic complication of sickle cell is chronic pain. Chronic pain is considered if pain lasts more than 3 months. It could be chronic pain with objective signs such as avascular necrosis or leg ulcer, or due to neuroplasticity of the peripheral or CNS. You know, neuroplasticity is a situation where there is the changes on how the brain responds to either intrinsic or extrinsic factors or triggers of pain, you know, and a change in the neural networking in the brain. You know, it may not necessarily be due to or be organic in terms of whether the pain is really taking place due to an organ malfunction or due to an injury to an organ such as the leg ulcer or avascular necrosis. It's just it just changes to how the brain responds to such pain. So that is neuroplasticity. Assessment should include its location, severity, factors that precipitate or relieve it, including biopsychosocial factors, and its effects on the patient's mood, activity, employment, and quality of life. Evaluate the patient's response to treatment, pain relief, the side effects, and functional outcomes to guide treatment. Assessment for chronic pain should be done annually. There are special tools that are used for assessing chronic pain. And management. Use long and short-acting opiates to manage chronic pain that is not relieved by non-opiates. Encourage the use of deep tissue pressure, massage therapy, muscle relaxation therapy, and self-hypnosis. And for neuropathic pain, use anti-neuralgic tricyclic antidepressants, e.g. amitriptyline. Refer for evaluation by psychologists if associated with anxiety and depression. Patients with progressive musculoskeletal conditions should be referred to orthopedic or rheumatology specialists. Refer to occupational therapists and psychotherapists to assist patients to gain optimal physical function and independence. So again, we can see the role of specialists. You know, it is multidisciplinary, that cannot be overemphasized. Endocrine complications. These include gonadal dysfunction, for example, low testosterone. The other, in the last lecture, we mentioned how the endocrine system can be affected by sickle cell disease because of repeated vaso-occlusion leading to ischemia and infarction in those organs. And then for patients who have on chronic and multiple blood transfusions, you know, they can have iron overload as a complication, and that iron is loaded or is impregnated into those organs, and to the extent that it affects the parenchyma of such organs and also affects the function of those gonadal or endocrine organs. So leading to hypofunction of those organs. So for gonadal dysfunction, measure weight and height and plot on an appropriate growth chart. Screen levels of testosterone, early morning total testosterone, 2 separate readings before 10 a.m. If at the age of 14 years in male patients there is evidence of hypogonadism, refer to an endocrinologist for further evaluation and treatment. For adrenal dysfunction, evaluate patients who have hemodynamic compromise during sickle cell crisis with sepsis for adrenal insufficiency. Refer to endocrinologists if there is evidence of adrenal insufficiency. For thyroid dysfunction, check for a history of chronic transfusion, a recognized risk factor associated with thyroid dysfunction. Refer to endocrinologists. For impaired glucose tolerance, patients with impaired glucose tolerance perform annual glucose tolerance screening with fasting plasma glucose in chronic transfused sickle cell disease patients. Refer sickle cell disease patients with impaired glucose tolerance or diabetes mellitus to an endocrinologist. For parathyroid dysfunction, evaluation includes screening with serum calcium, phosphorus, alkaline phosphatase, and parathyroid levels. Do neck ultrasound to exclude hyperthyroidism. Screen for hypothyroidism in chronically transfused patients from the age of 10. And refer patients with evidence of parathyroid dysfunction to the endocrinologist. Gastrointestinal complications. These include chronic sickle cell hepatopathy, and the components include cholelithiasis, cholelithiasis, sickle cell cholangiopathy, and transfusion iron overload can lead to cirrhosis. Evaluation include liver function test, abdominal ultrasound, clotting profile, endoscopic retrograde cholangiopancreatography, liver biopsy, and so on. So if there are abnormalities in this test and the changes are evident, you refer the patient to hepatologist. Viral hepatitis. There is an increased risk of viral hepatitis in sickle cell disease patients due to blood transfusion. Also depends on the prevalence in the community. So once this is detected, you refer the patient to hepatologist and monitor hemoglobin concentration. Ophthalmic complications. Proliferative sickle retinopathy. Repeated vaso-occlusion and ischemia in the retina leading to the release of factors that promote vessel formation. That is the pathophysiology. It referred persons of all ages with proliferative sickle retinopathy to an ophthalmologist, retina specialist for evaluation and possible laser photocoagulation therapy. So I want to mention here that actually, even to make this diagnosis itself, the proliferative sickle retinopathy is not commonly done in routine practice, even by hematology. So the important thing to do is to annually, on an annual basis, refer patients to ophthalmologists for screening, as a way of prevention, as patients come to clinic on every year, they should be referred usually from the age of 10, they should be referred to the ophthalmologist to screen for this proliferative sickle retinopathy. Refer children and adults with vitreoretinal complication of PSR refractory to medical treatment for evaluation and possible vitrectomy. Again, this is for the ophthalmologist. So once we are sending them on annually for this assessment for monitoring, once the ophthalmologists detect these complications, they will go ahead and treat. Psychological complications. Conduct psychological assessment for all patients, both children and adults, routinely. Conduct neuropsychological assessment when neurological complications and/or educational problems are indicated. So again, there are special tools that are used for these assessments. And like in our center, currently we have a psychologist in our clinic that screen them, that conducts this psychological test. And once issues are detected from this assessment, they are referred to the mental health physicians for treatment. Assess mood and emotional problem, assess physical and social function, assess coping strategies in relation to pain, symptoms, and complications, assess general health and related quality of life. Assess attention and concentration and executive function initially, followed by comprehensive neuropsychological assessments. Offer psychological therapies, e.g. cognitive behavioral therapy, individual and/or group or family sessions as appropriate. Again, this is where the mental health or clinical psychologists specialists come in. Suggest available psychological self-resources, including internet-based interventions. Liaise with schools and colleges to negotiate additional or special educational support to compensate for neuropsychological complications and poor school performance. Cardiopulmonary functions, pulmonary hypertension and complications. So an example is pulmonary hypertension. Evaluation includes screening tests such as echocardiography or measurement of N-terminal probrain nitriuretic peptide, proBNP, and/or 6 minutes walk distance test. If pulmonary arterial pressure is greater than 40 millimeters of mercury or thoracoscopic regurgitation jet velocity is greater than 2.5 meters per second, or NT-proBNP is greater than 164.5 picogram per milliliter, and or if the 6 minute walk is low, less than 333 meters, do confirmatory tests. And the confirmatory test is to perform a right heart catheterization. Again, these are highly specialist programs or interventions. So patient should have echocardiography on annual basis, to rule out pulmonary hypertension. Treatment include if the mean pulmonary arterial pressure is greater than 25 millimeters of mercury, refer to a pulmonary hypertension expert for treatment using target therapies such as prostacyclins analogs, phosphodiesterase type 5 inhibitors, or endothelin receptor antagonists. Renal complications. There is a spectrum of these renal complications, as we all know, starting with microalbuminuria. If there is microalbuminuria or macroalbuminuria, order a 24-hour urine test for protein. Refer people with proteinuria greater than 300 milligram in 24 hours to a nephrologist for further evaluation. For adults with proteinuria without other apparent causes, initiate angiotensin-converting enzyme inhibitors therapy. For children with microalbuminuria or proteinuria, consult a nephrologist. Consider patients with modest elevations of serum creatinine, 0.7 milligram per deciliter in children or greater than 1 milligram per deciliter in adults, to have renal impairment and refer to a nephrologist for further evaluation. Give SCD inhibitors therapy for renal complications when indicated, even in the presence of normal blood pressure. Renal replacement therapy, e.g. hemodialysis, peritoneal dialysis, and renal transplantation should be used in sickle cell disease if needed. Nocturnal enuresis. Routinely ask parents about nocturnal enuresis in the child with sickle cell disease age 6 years and older. Document presence of enuresis and give information to parents and other caregivers. Assure parents that nocturnal enuresis is a known and common complications of sickle cell disease. Investigate presence of snoring, possible obstructive sleep apnea, and nocturnal hypoxemia. If these are present, refer child to ENT surgeon for further evaluation and management. Refer child to enuresis management program if one exists, for training in use of enuresis alarms, and provide family counseling to avoid punitive measures that further lower the child's self-esteem. Do not withhold fluid intake in the management of enuresis in children with sickle cell disease. Chronic neurologic complications. Evaluate children and adults who present with new onset seizures for acute stroke or evidence of cerebrovascular disease. Evaluate children and adults who present with new seizures and no evidence of stroke for other causes of seizures such as epilepsy. Consult with neurologists to manage chronic recurrent seizures with appropriate anticonvulsants. Do not give meperidine or petidine to people with sickle cell disease who have a seizure disorder because its metabolite, norperidine or norpetidine, is a neurotoxin which is associated with the seizures. Stuttering or recurrent priapism. That is a counterpart of the acute complication of priapism. Clusters of self-limiting, there are clusters of self-limiting episodes of priapism. Diagnosis involve taking history of frequency and duration of erections and examine the phallus. Do corporal blood gas analysis and corporal Doppler ultrasound. Management includes instituting simple measures such as bladder emptying, hot bath hydration, adequate analgesias and opiates, and gentle exercise. Consult urologist if no detumescence after 2 hours for evaluation and possible surgical intervention. Preventive measures include giving slow oral ethylephrine starting with 25 milligram daily nocti. If there is no satisfactory response, increase dose by 25 milligram every 2 weeks to a maximum of 400 milligram in divided doses. Or oral pseudoephedrine 30 milligram nocti in children of less than 10 and 60 milligram nocti in adults. Consider the use of hydroxyurea. Educate male patients and parents of adolescent patients about the risks and the emergency nature of priapism. self-treatment measures and to seek medical help if episodes exceed 2 hours. So this is, again, this major reference is from the SPARCO Standard of Care recommendations for tertiary healthcare facilities. Thank you for listening.
Thank you very much. We appreciate you. As usual, you have done justice to it. And I sent you a WhatsApp message that you should help me to send, so I could send to the participants. Thank you so much. We appreciate you. So it's time for question and answers. And I'm going to hand over to Dr. Uriaku to moderate that. Over.
Thank you, Prof. I'll start by appreciating Dr. Issa. In short, our participants too are appreciating you on the chat. You are making hematologists out of us. Thank you, sir, for that, breaking down acute and chronic complications for us. So it's quite a interesting ride. Sir, there are a lot of questions for you.
Okay.
I'm starting. Somebody wants to know, what's the life expectancy of those with sickle cell disease?
Okay. Life expectancy of
Those with sickle cell disease, according to the person, that rumor has it that they died before 40 years.
well, it depends on the environment. I believe in Nigeria, what is the life expectancy of an average Nigerian, for example? And then you now cone it down to the sickle cell disease patients. Yeah, if there is, for sickle cell disease patients, I think currently with improved management and newer interventions such as hydroxyurea, some of them can actually live long. We have some of them that are grandparents, we have professors who have sickle cell disease. They have live long and have a good career, enjoy their career, and they have even become professors and achieved their life goals. So it is not really a death sentence. Sickle cell disease is not a death sentence, but however, their life expectancy compared to normal individual is lower. I cannot say exactly what it is, but this is because of complications that they develop, especially of vital organs such as the kidney and the heart, cardiopulmonary complications that can shorten their lifespan. But again, there has been improvement over the years. It's not like before. Sickle cell disease, if there is no intervention at all, most of them die before the age of 5. Is that okay? So, but with intervention and with the cooperation of the patient, if they are following and adhering to all the management and their medications, and they are cooperating, they can live well and have a good quality of life, so it is not a death sentence. Thank you.
Thank you, sir. Then some people wants to know, why is it that you have more painful crises in children more than adults? Then also, there's another question on who gets more painful crisis. Then there's another question too, that somebody was not having crisis as a child, but now is an adult, is having more frequent painful crisis compared to when the person was a child.
Okay. Well, why children have a more painful crisis than adults. I think number one is more of sickness behavior. You know, in children, don't hide their feelings. Once they have pain, they will express it. They will cry, they will scream. You know, they don't pretend. You know, but adults, they may be having a crisis and they will not say it. They will just be bearing it, and they may still depending on the severity, and they may still go about their normal duties. You know, unlike children will express it. They will always scream and express their pain. So that is to show you that the frequency of crisis may not really be too different between adults and children. It's just the way of expression or the illness behavior pattern between adults and children. And then for children, you know, they are still learning. You know, even the discipline to avoid those things, those precipitating factors that will tip them into crisis. You know, they are still learning, and some of them, they don't adhere to those precautions that they should take. Unlike adults over the years, they've already known, and from experience, you know, what can lead them to crisis, what can cause crisis for them. And so they are able to avoid such things. So at the end of the day, their frequency of crisis is less than what we see in adults. Then I think the other question is saying that why is it that initially for some patients, they don't have crisis, but when they grow up, when they grow older, they begin to have more crisis, right?
Yes, sir. Yes, sir.
Yeah. So this may be due to, you know, the fact that probably the change of environment, a change of behavior, or even some complications setting in. You know, as you grow up, as the patient, as they grow up, their likelihood to be more there's likelihood for chronic complications to develop, especially if they are not doing the right thing. You know, so as those complications are setting in, you know, they begin to have more and frequent crises. Or if they have changed their behavior pattern, their social life, and so on, you know, they can have, that can lead to more frequent crises, right? So I don't know whether
Thank you, sir.
answer the question.
Okay.
Yeah.
No, you can go on, sir.
Yeah. No, over. Thank you.
Oh, all right. Thank you, sir. Our next question has to do with hydration in painful crisis. I'll take all of them at once. Why is 5% dextrose saline or 5% dextrose water the preferred infusion over normal saline? And why is 10% glucose dextrose not recommended in VOC? And another question goes this way: can Ringer's lactate be used in hydration?
Okay, the 5% dextrose is preferred because of because it's easily excreted through the urine. You know, it doesn't stay long in the circulatory system. You know, whereas hypertonic saline or normal saline, you know, is more hypertonic. It can stay, and once it's staying longer, there will be possibility of overload, fluid overload. You know, because the sickle cell patients already, they are anemic, and there is already a plasma expansion to compensate for the plasma volume. Is that okay? So if you are hydrating them and you are giving them hypertonic fluids, like the normal saline, or no, normal saline is not hypertonic, but it's just like what is obtainable in the normal plasma. And then 10% dextrose is actually hypertonic. So these fluids stay long in the circulation, and then coupled with the already expanded plasma volume, it can tip them into cardiac failure. So that is why they are avoided. So you use dextrose saline that can circulate and make the blood, improve the rheology of the blood, to circulate, and is quickly excreted in the urine. As you are giving, it is diluting or making the blood flow very well and circulate very well, and is continually excreted in the urine without being retained in the system. The Ringer's lactate, I think it has some electrolytes in it. I think it's usually used when patient is having diarrhea also. So if patient is not, patient is not having electrolyte changes, there will be no need to use Ringer's lactate.
Thank you, sir. Then, in aplastic crisis, what is the line of treatment if patient declines blood transfusion?
Sorry. The aplastic crisis, as we said, the most common cause is parvovirus. Actually, most of these viruses or opportunistic infections are self-limiting. Sometimes even without intervention, over time, they can overcome it. It will, when it goes through the cycle, or the course, patient recovers. So if patient is not agreeing to blood transfusion, we mentioned about giving immunoglobulins, to improve the patient's immunity to be able to handle the virus. Is that okay? And then the other thing that can be given probably is to give erythropoietin therapy to help boost erythropoiesis. Is that okay?
So, still on blood transfusion, sir.
Yes.
Somebody wants to know the difference between red cells concentrate and sedimented cells.
Well, a red cell concentrate is a better product than the sedimented red cell. Red cell concentrate, you sort of subject the whole blood to, you centrifuge it, called centrifuge, and so that the red cells are well packed. They are well packed, and you remove as much plasma as possible. It has very little plasma in it. That is red cell concentrate. Whereas sedimented red cells is like a crude way, to just sediment the red cells, sometimes by keeping the blood back for maybe some hours in the fridge, in the blood bank fridge. For the red cells, by that process, you may not be able to remove much of the plasma. There will still be some significant amount of plasma in the sedimented red cells. So that is just the difference.
Yes, sir. Thank you, sir. Is it always necessary to give diuretics during blood transfusion?
Yeah, but like if you are giving concentrated red cells, packed red cells or red cell concentrates, you may not need to give the diuretics. But again, it depends on the level of anemia when the patient is present. If the patient was having severe anemia, it's likely that he had more plasma expansion, even with the red cell concentrate, you may still have to give diuretics. But if it was moderate anemia, and we are giving red cell concentrate, you may not need to use diuretics.
Thank you, sir. Is there any difference between hypersplenism and splenomegaly?
Yes, there's a difference. Somebody can have a splenomegaly is enlarged spleen enlargement. You can have splenomegaly without hypersplenism. But and then on the other hand, hypersplenism is increased function of the spleen, as we mentioned earlier. And most of the time, you may not necessarily have splenomegaly in hypersplenism, right? Or even if the spleen is enlarged, it will just be mildly enlarged. That is the difference. And in hypersplenism, you have a situation where there is increased destruction of red cells or even platelets in the spleen, leading to cytopenias. Whereas in splenomegaly, there may not be increase in destruction. What in splenomegaly, there may be pooling, like in sequestration crisis. In splenomegaly, it may even be due to hemopoiesis taking place in the spleen, that is extramedullary hemopoiesis. And some splenomegaly may even be due to infiltration of malignancies from other organs, there is metastasis. So there's a difference. Those are the differences, between splenomegaly and hypersplenism. Hypersplenism, most of the time it causes, it causes cytopenias. And in hypersplenism, when you do reticulocyte count, the reticulocytes count is increased. There's reticulocytosis in hypersplenism.
Thank you, sir. Is there a role of oxygen therapy in chronic pain?
In chronic pain?
Yes, oxygen therapy in chronic pain.
Well, unless there's unless respiration is compromised, or if there's severe anemia, but if the patient is, if you do pulse oximetry, for example, and the oxygen saturation is is normal, is within normal, 95% and above, there will be no need to do oxygen therapy. So it depends on what is precipitating the pain itself or the chronic pain.
So, sir, what is the management of opioid overdose in painful crisis?
Opiates overdose.
Overdose in painful crisis.
Well, we know that one of the side effects of opiates it suppresses respiration. It suppresses the respiratory center, and then patient will not be and then also affecting the oxygenation of the tissues. So as we mentioned in the lecture, what we need to do is to stop the treatment, the opiates, is to discontinue the opiates, so that it will be cleared in the system and the patient can resume normal respiration. And then we should use other analgesics, other classes of analgesics.
Is vosoritol readily available?
Okay, voxelotor.
Yeah, is it readily
Yeah,
available?
it is not readily available, and in fact, it is. I'm not sure it is approved by NAFDAC in Nigeria, but in some countries it has been approved, and then it is also being investigated. It is still undergoing clinical trial. So it's not easily. I will not say is easily available. It's not.
Are there data in Nigeria on pentazocine dependence or addiction among sickle cell disease patients, especially in Nigeria? Because I've had situations where, some of those patients, somehow they feel they are being denied giving pentazocine when they are having crisis.
Yeah, well, I'm not sure it is. I'm sure data will not be lacking, but from my personal experience, pentazocine is the most common drug being abused by sickle cell disease patients. Maybe because it's easily available and it's relatively cheap or affordable. So it's quite a common, and even by the way of mechanism of action, it's known that that patients are easily addicted to pentazocine than morphine. So they are all centrally acting drugs. So it is actually a problem, and the use of those drugs should be cautious. But again, we should make sure that we don't deny the patients from getting adequate treatment of their pain. Because one of the things we mentioned when we are evaluating pain is that we should go with the patient's assessment, and give the appropriate drug. If it is severe, we use drugs like morphine or the pentazocine itself, but patients, very importantly, should be educated and should be well counseled about the side effects and the tendency to get addicted to the drugs. most of the patients are quite responsible. That is one thing that I've observed. Sickle cell disease patients are responsible and will not place themselves in a position where they will become addicted. But the common thing among health workers, we always assume that the patients will abuse these drugs. Many of them don't want to abuse such drugs, so we should give them the benefit of the doubt, and they should always be well educated in order to prevent that. I'm sure there won't be, there should be data out there within the country about pentazocine addiction. I've read about a case report about pentazocine addiction, but I don't know whether there are case series or a very comprehensive data, but I'm sure that will not be lacking when we search the literature very well. Thank you.
Thank you, sir. At what age can an infant show signs of VOC? If the child has not received newborn screening.
Okay, usually children begin to present with signs and symptoms of sickle disease from the age of between 4 and 6 months, when the fetal hemoglobin has dissipated in their system. From the age of 4 months to 6 months, they begin to have signs and symptoms. Vaso-occlusive crisis, you see them with hands and foot swelling, known as dactylitis. Some of them, they will present with anemia, with sequestration crisis, although sequestration crisis is much later, from about the age of between 1 and 2 years. That's when they present with the sequestration crisis. But from the age of 4 months to 6 months, that's when they begin to present, if they have not been diagnosed.
Okay, sir. You might have to increase your voice a bit, sir.
Okay.
If you don't mind, sir. If you don't mind, sir.
Okay.
Yes. Well, we are going into hydroxyurea questions. That will mark the end of questions from your first lecture. Then we go to second lecture's Q&A. So, hydroxyurea, is it for all sickle cell patients? Is it for all patients with sickle cell anemia?
Yes, hydroxyurea is a disease-modifying drug, and previously it used to be for patients with severe disease, like admissions, 2 or 3 admissions per year, 2 or 3 blood transfusions per year, and so on. But because it is a disease-modifying drug, it is recommended for all patients now, And one thing with sickle cell disease is that patient may not have clear phenotypes that present, clinically. That will cause the patient to go to the hospital. But it doesn't mean that the disease is not there, and it doesn't mean that the disease is not going on subtly and destroying other organs. The patient may not have need for blood transfusion. Patient may not have vaso-occlusive crisis that will require admission. But the disease is there and is affecting the organs, causing subtle renal damage, causing subtle retinal damages, causing subtle osteonecrosis, and so on. You understand? So that is why the patients need hydroxyurea, irrespective of whether he's having crisis or not, because hydroxyurea modifies the disease in terms of increasing the fetal hemoglobin, increasing cellular hydration.
Dr. Sir, as if we have lost you. Dr. Sir?
Let's just give him a few minutes. I think it's a network fluctuating.
Yes, all right. Thank you, Prof.
Hello?
Hello, we lost you briefly, but you can continue, please.
Okay. So I was saying that hydroxyurea previously was being indicated, it was being recommended for patients who have severe disease in quotes, in bracket, because most of the time when we say severe disease, we look at the phenotypes, how the patient presents clinically, whether being how frequent he's being admitted in the hospital, how frequent he's being transfused, how frequent his vaso-occlusive pain are. But that is beyond that. The disease is beyond the clinical manifestations. It is an ongoing thing that is gradually affecting the organs and systems, to the extent that, the complications will all of a sudden appear, without the patient knowing it. So, and that is why hydroxyurea, being a disease-modifying drug, is now being recommended for all patients, because it increases the fetal hemoglobin, which is known to ameliorate the sickling process. And then it also increases the cellular hydration, to maintain the blood in flexible form that will circulate and reduce that sickling process, as we discussed last week. So hydroxyurea is recommended for all sickle cell patients.
Thank you, sir. Then it takes us to effect of hydroxyurea. Is there any relationship between hydroxyurea, taking hydroxyurea and healing of leg ulcer? And also, what's the relationship between hydroxyurea and infertility? That will be our last question for the first lecture.
Okay. Hydroxyurea and leg ulcers, for most patients, it works. It helps in the wound healing. And then how does it do that? By generally improving the cellular hydration, and then also improving the fetal hemoglobin and oxygen delivery to tissues. Is that okay? So that is how it does it. But it has been found that that for some patients, it's actually slows down the healing process. And for those patients, usually it's recommended that hydroxyurea should be withdrawn, should be discontinued for those patients. So that is that about hydroxyurea and leg ulcer. I can't remember the second part of the question.
Whether there's a relationship between hydroxyurea and infertility.
Okay, hydroxyurea and infertility. Yes, in fact, that is the most common barrier, one of the most common barriers to hydroxyurea utilization for both the patients and even health workers. You know, we know that hydroxyurea is also used for management of some malignancies, like leukemias, and because of that, you know, patients think that it causes infertility, and it makes them to not want to use hydroxyurea. So, but over the more than 2 decades or 3 decades of hydroxyurea use, you know, it has been found that hydroxyurea does not really affect fertility. You know, if there's any case report at all, maybe 1 or 2 cases. So that should not be a barrier. But even with that, there's any patient that is on hydroxyurea that is in productive age, you know, it is usually advised, especially for the women, it's usually advisable that they stop using hydroxyurea for about 3 months before they take in, and when they take in, they'll also not use hydroxyurea for the first 3 or 6 months in the first trimester and second trimester, and thereafter they can start using hydroxyurea again. You know, it does not really affect fertility as such.
Thank you very much, Dr. Issa. Once again, you have made it pretty easy for all of us. Thank you very much. So we take questions from your second lecture. Can I start, sir?
We
Yes.
have only 10 minutes more. So just
Okay.
select few. Thank you.
Okay. Thank you, Prof. How often should routine neuropsychological assessment be done for these patients?
Well, how often? Usually annually. Annually, once a year, you know, patient should do this psychological assessment.
Okay.
Yeah.
What is the role of a low-dose ASA as a blood thinner in management of sickle cell disease?
Well, in our last lecture, we saw how sickle cell disease is a procoagulant state, you know, due to endothelial damage, and then sometimes the sickle cell patients, they have reactive thrombocytosis. That's when their platelet counts are more than 450. Some of them, you see them having platelet counts of 700, 800 times 10 raised to power 9 per liter. So those patients usually will benefit from low dose aspirin, and in order to sort of inhibit the platelet function and activation. So that is the role it plays. Yes, thank you.
Okay. For the psychotherapy, you said annually. When do we institute it? Is it during crisis or is it part of the psychotherapy? Is it during crisis that you offer a patient psychotherapy, or should it be part of their routine management?
Okay, I was talking about psychological assessment, not really.
Okay, not
Yeah,
psychotherapy.
the psychotherapy will now come in after you've done the psychological assessment and found out that the patient needs intervention or needs some.
There will be a presentation on that later, so let's move
Okay,
on.
so good, good.
Okay, thank you, sir. Thank you very much, sir. Then the last question, can opioids be used for children? Management of painful crisis in children. Thank you, sir. That's the last
Yes,
question.
yes, it can be used from that table that we shared with the opiates can be used for children. Yes.
Thank you, sir. Thank you very much, sir.
Thank you.
Professor Friska, thank you very much, ma'am. We are through with the Q&A. Professor Friska. Mr. Shola?
Yeah, yes. Mr. Priska, she's
Yes.
here. No.
Okay. We are through with the Q&A.
Okay. And then if Professor
Apologies, please, I was muted. Sorry. Apologies. Good morning, everybody. And you will agree with me that this has been a fantastic time again. And we're truly so delighted. Thank you so much. Specifically for bailing us out this morning. God bless you, Dr. Isa Hezekiah. We are truly so grateful. And thank you to all very wonderful and engaging participants. You are the best. The questions you are asking shows, one, that you are here, not just virtually. It seems to me as if you are here physically. And we are so grateful. Thank you so much. God bless you. Thank you for all the questions you've asked. Make sure that you take note of them. Professor Obi promised to help send some information that will give us opportunity to even attend some other virtual trainings, capacity building, workshops, and so on and so forth. And then we hope that if Dr. Isa also has some reading materials based on all the questions the people are asking, you can send them as well. So we're putting together a genetic album for sickle cell disease, and we do hope that we'll be able to find it very useful as a resource for participating in this program. Thank you so much. It's been an awesome 2 hours. I never knew we have just 5 minutes more. And there was no scenario of introduction of all of those things. We went straight into it, and you have done very well. We thank you and we appreciate you. Okay, so we have 5 minutes for the briefing meeting. And on this note, I'm going to say a very big thank you to everybody. Please take note. For you to get a certificate of completion, you cannot afford to miss any of the classes. I know there are issues with over 500 other people who are not able to join us. I've sent a message to them. We are planning a second batch. You'll be communicated. They will be communicated at the appropriate time. And so please let those of us here concentrate. Do not send the link to anyone at all. And just be here. And as we go along the line, be taking notes, because post-test becomes important. If you have taken your pre-test and you have any issue concerning it, please just send your message to me, and we'll try as much as possible to get you sorted. I think that's all the housekeeping information that I have for us. I don't know if you have any information from the panelists, please just raise up your hand and I'll recognize you in the next 4 minutes remaining before we close. Okay, I did not see any hand up. And I want to assume that we are clean and dusted for this morning. This week marks the end of week 2. We'll be back by the grace of God, not missing, not broken, and no trouble of any sort. By next week, Friday, time remains 8 p.m. to 10 p.m. And on Saturday, 7 a.m. to 9 a.m. in Nigeria. And vis-a-vis Ghana, 7 p.m. to 9 p.m. on Friday and 6 a.m. to 8 p.m. on Saturday morning. So thank you very much to our moderator.
Sorry, Professor Prescott, there are some hands up.
Okay, thank you. I didn't see them. Can you please help me to identify them and let's hear what they have to say?
Should I allow them to speak?
Oh, I was talking about the panelists. I didn't know that. Okay. We have just 2 minutes more. Okay, permit 1 or 2 people. Let's just hear. Concerning this presentation, please, if it is any other thing, please send it to the WhatsApp group and then we can continue from there. Okay, over to you. Just please select 2 people.
Zacchaeus Olofin.
Yes, thank you very much, man, for the presentation, for organizing this program. I'm very sorry I missed yesterday's lecture. Unfortunately, I didn't get the notice on time. I didn't check my WhatsApp because I kept looking through and I didn't see until this morning.
Okay, please get back to me on WhatsApp. Thank you
Okay.
for your question. Can I have any question related to this presentation? Anybody, Mr. Ashola, please just randomly get 1 more person. We have 2 minutes still. Okay.
Mr. Ben Adekunle.
Please look for 1 person from Ghana after this. If there's
Hello.
anybody. Thank you.
Hello.
Go ahead. We can hear you.
Yes, the same question with the person who
Please,
just
okay, please get to me. Get across to me later.
Okay.
Any question relating to the presentation is what we want to attend to now. Okay. Is there any other hand up? Okay, just 1 minute more. And that 1 minute, I will allow Dr. Oriaku to say vote of thanks to Professor Isa Hezekiah. Over.
Thank you, Prof.
I close the meeting after that.
All right, ma'am. Thank you, Dr. Isa. We appreciated your time, the wealth of knowledge you have given us this morning, and your patience to answer all our questions so that we even understand the lecture better. You had a marathon of 2 lectures. We know it was not easy, but we thank you. We assure you it was impactful. We enjoyed it, and we can assure you that we'll go and apply what you have taught to us this morning. And for every one of us, the participants, the panelists, I appreciate all of you for coming out this morning and being part of this training this morning. May we have a wonderful weekend and God be with us till Friday evening. Thank you. Have a wonderful weekend. It's closed.
Thank
All right,
you.
bye-bye, everyone.
Bye.